Welcome to Guideline Updates by MedStudy. I'm Dr. Michael Gomez. This guideline update is regarding Neonatal Resuscitation Program, 8th edition, released in June of 2021 by the American Academy of Pediatrics and the American Heart Association. Neonatal resuscitation has been a critical part of newborn care for many years. In 1952, Virginia Apgar, an anesthesiologist at Columbia University, developed the Apgar score as a rapid method for evaluating neonates immediately after birth in response to resuscitation. For many years, the Apgar score remained the accepted method of assessment of newborns after birth. In 1987, the Neonatal Resuscitation Program was started in the first edition, and there were extensive offerings for training of faculty by 1988. And a formal textbook, the Textbook of Neonatal Resuscitation, was released at that time. Within a year of its release, NRP had reached 48 states and Canada with 184 national faculty and nearly 1,000 hospital-based instructors trained. The program continued to expand worldwide and is now offered to over 5 million healthcare professionals who've been trained and retrained in over 130 countries. NRP has approximately 18,500 active instructors and nearly 200,000 learners completing NRP provider courses every year. Again, released in June of 2001, NRP 8th edition remains the seminal text authority for care of newborns at delivery. There are a number of changes that were made in the guideline that's attached below or linked to below. This update will focus on the 8th edition practice changes in NRP, of which there are 6. I'll discuss these 6 practice changes with regards to what was previously available in 7th edition and what's currently available in the 8th edition. The first practice change is regard to umbilical cord management plan added to the 4 basic questions when attending any deliveries. This umbilical cord management plan was intended to replace how many babies at the question, because how many babies is often known when the delivery team is asked to attend. The NRP 7th edition 4 pre-birth questions included gestational age, amniotic fluid clear, how many babies, which is being replaced, and additional risk factors. NRP 8th edition 4 pre-birth questions include gestational age, amniotic fluid clear, additional risk factors, and again, the umbilical cord management plan, which has to do with delayed cord clamping. A review of this guideline in more detail will give you more information regarding umbilical cord clamping. We'll not review that in any more detail here. The initial steps have been reordered and to recommend common practice. NRP 7th edition initial steps are somewhat verbose and slightly confusing in that it says to warm and maintain temperature without any specifics, position airway, clear secretions if needed, dry and stimulate. Current practice, which is reflected in NRP 8th edition, says the initial steps are simplified to warm, dry, stimulate, position, and suction airway if needed. The simplification should clarify and make this particular portion of the practice somewhat easier to do. The third practice change is the use of electronic cardiac monitoring recommended earlier in the algorithm. NRP 7th edition recommended that the electronic cardiac monitor be introduced or applied to the patient as the preferred method for assessing heart rate during cardiac compressions. The 8th edition moves this somewhat earlier so that electronic cardiac monitoring should be used as soon as an alternative airway becomes necessary. So the introduction of an endotracheal tube or the introduction of a laryngeal mask airway. This is the recommended method of assessing the heart rate during resuscitation time. The 4th change and 5th change are somewhat related to each other. With regards to the use of epinephrine, both intravenously and intraosseously and endotracheally. NRP 7th edition provides a dose range of 0.01 to 0.03 milligrams, which translates to 0.1 to 0.3 milliliters per kilo for the initial intravenous or intraosseous dose of epinephrine. And the endotracheal dose range was 0.05 to 0.1 milligrams per kilo, which translates to 0.5 to 1 ml per kilo. This dose range proved confusing at times and has been simplified in NRP edition 8 suggesting a single dose for intravenous or intraosseous initial dosing of 0.02 milligrams per kilo or 0.2 milliliters per kilo for intravenous or intraosseous dosing. And the suggested endotracheal dose is 0.1 milligrams per kilo or 1 milliliter per kilo, again, rather than a dose range. Related to this range has also, this range change to a simplified dose has also been simplification of the flushing of epinephrine after administration. 7th edition, again, gave a range of 0.5 to 1 ml of flush, of saline, normal saline flush after administration of intravenous or intraosseous epinephrine. The current recommendation in NRP version 8, edition 8, says that the flush should be with 3 mLs as a flat dose and applies to all weights and all gestational ages. The last change has to do with the expanded time frame for cessation of resuscitative efforts. Resuscitation is a busy and stressful exercise, and 10 minutes can pass very quickly. 10 minutes is the recommended cessation time if there's confirmation of absence of heart rate after 10 minutes of successful effective resuscitative efforts. NRP 7th edition recommends, again, that resuscitation efforts can cease after 10 minutes. Again, with all the confusion and all the activity around the delivery, that has been reconsidered in version 8. And if confirmed absence of heart rate after appropriate steps are performed, consider resuscitation cessation now after 20 minutes. That additional 10 minutes gives the team adequate time to consider all efforts and make sure that all the portions of the algorithm have been exercised. These 8th edition practice changes are fairly straightforward and in fact simplify the resuscitation process for the team in the delivery room. There's a small amount of controversy surrounding umbilical cord clamping and its effects, which you can read in more detail in the guideline. And there's a small amount of controversy around the time duration or when to cease resuscitative efforts, but these are not significant and are not as significant as earlier changes, such as ceasing the practice of tracheal aspiration for meconium-stained amniotic fluid. As an active, regular practitioner of neonatal resuscitation, the program has evolved tremendously over the more than 30 years of practice, and will continue to do so in the future on a regular cycle based on scientific evidence and expert opinion. The 2-year training cycle and education cycle for NRP ensures that you'll always be provided with an opportunity to update these critical life-saving skills for newborn infants. Thank you for your time. This is Michael Gomez here with guideline updates for MedStudy.